This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, I'm going to be speaking with Ash Vasireddy around the successes and challenges of major trauma networks within the UK. So what I'm going to do in the episode is really dive into the topic of major trauma networks, but also look at how they've started to improve patient outcomes since their inception. We're also going to explore the positives and indeed the challenges faced by these networks and look at some of the insights into their impact on survivability and indeed survival rates across the network, but also the integration of them within pre-hospital services and indeed the utilization of various technologies. So to do this, I'm joined by Ash Vasireddy. He's no stranger to the podcast and joined me before talking about pelvic trauma. He is a trauma surgeon at King's College Hospital, London. He also is quite unique as he works as a pre-hospital care doctor and indeed consultant at Essex and Herts Air Ambulance. He is the trauma lead at King's College and also ensures that the MTCs, so the major trauma centres, are functioning effectively from an orthopaedic perspective and fosters relationships within the network to improve outcomes. Ash, welcome to the podcast.
Thanks very much for the invite again. Appreciate it.
I wondered if we could just start, Ash, by just digging into, indeed for international listeners, just a brief explainer on what major trauma networks are and how they function within the UK health system.
So major trauma networks, you could describe them as a hub and spoke model in general. So you've got the major trauma centre that sits in the centre of this hub and spoke like a bicycle wheel with all the other hospitals, typical district general hospitals that we label as trauma units, who feed into the major trauma centre with complex trauma patients. And obviously, as a major trauma centre, we sometimes transfer patients back to their home trauma unit if they live near there for further rehab, etc., before they're getting transferred home. And that's how that works from a pre-hospital care setting. Depending on the network one works in, ambulance services or pre-hospital care teams can actually bypass a trauma unit if it's near the scene of the accident and actually take patients directly to the major trauma centre if that's the appropriate place they feel that patient ought to be treated. And that's in general how it works. In terms of the UK itself, there are slight differences between trauma networks. For example, within London, as you know, there are 4 big trauma centres in the corners of London. All of them operate, one would label kind of an exclusive system where all trauma patients generally are preferentially taken to the trauma centre and then managed, treated, and then transferred back out or discharged home. Other trauma networks operate slightly differently. So the East of England, for example, which is a patch that I cover from the Essex and Herts point of view, will preferentially want patients to go to the trauma unit first, just to get some initial assessments, some imaging, etc. And then they'll have them transferred to the trauma centre if appropriate. And obviously there's multiple reasons for why that is and why there's variations in geographical areas, but it's largely to do with local capacity and patient flow issues.
So just from a historical context, Ash, could you speak to, so fundamentally we realised indeed 5, 10, 15 years ago that secondary transfers were really sometimes not only adding to morbidity, but certainly adding to mortality. And it was just trying to eradicate this concept of secondary transfer. But could you maybe speak to the main reason why major trauma centres came together from a historical context?
Yes. So the UK as a whole, we were very much late to the party on major trauma networks. There had been up-teen reports highlighting increased mortality and morbidity in trauma care in general. I mean, it's one of the reasons that London's air ambulance was set up back in the late 80s was because of one such report by the Royal College of Surgeons of England. But trauma care during the late noughties, so the late 2000s, was getting an increased perspective. I think kind of going back, it's just kind of come to me now. There was basically, I think, one of the Labour ministers was accosted at a hospital. And I can't remember if it was like the Prime Minister or like obviously the leading minister, about how some patient was doing really badly and trauma care has really done poorly. And that was a kind of lay member of the public mentioning that. And then it kind of just gained momentum from there on in. And then a national clinical director for trauma care was appointed. That was Keith Willett, who's a kind of revered, respected figure in the orthopedic trauma world. He is appointed as that. And there were a number of reports, typically the NCBOD report, which is the national report looking at emergency care. And there was a National Audit Office report that actually, I think it was at 2009, 2010, highlighted that we as a country had about a 30% increased mortality rate for trauma patients compared to an equivalent geopolitical country, i.e. equivalent first world country, as you describe, or developed country. And they tried to highlight that that was the issue, and there was lots of money being lost through people not being able to get back to work, not paying taxes. So there's lots of financial issues as well, and just overall morbidity and mortality issues. So that started, and then off the back of that, major trauma networks were then kind of thought of as a model to use to manage such patients. And it, there was such networks already kind of existing for neurosurgery, for pediatric care, for liver patients. There were lots of these systems already, so everyone thought we could use a similar kind of thing. And so the plan was in 2013 that England would have all of its major trauma centers and networks set up. There was a little bit of political pressure because the Olympics were coming up in 2012. And because of that, London set up much earlier to get everything ready for it. So in 2010, April 2010, London started its major trauma networks. I'm sure, as you remember, kind of George's, King's, and Royal London were all there. I think Mary's opened slightly later, and then everything was up and running a good year or two before the rest of the regions. And then more recently, kind of Scotland, Wales, and Northern Ireland set up their trauma networks. And as I say, that's how it's kind of been, with the trauma center at the middle and everyone kind of feeding patients into it, and then patients moving in and out along those lines.
So let's look at some of the positives from the trauma networks that have come to pass since their inception and indeed deployment within the health ecosystem in the UK. Could you maybe speak to some of the most significant positive outcomes since their implementation?
Yeah, so interestingly, in like 2020 or to 2019, 2021, around that period, there was a tweet actually tweeted out by NHS England highlighting a survival of around 300 to 400 patients per year throughout England just because of the network setup. And that's not through a bunch of new trauma surgeons, a bunch of new A&E or new hospitals opening. It's just through the fundamental infrastructure setup of a network. So that, significant survivors, the significant morbidity improvement. There's been an article published by Chris Moran, who, after Keith Willett, was the next national clinical director for major trauma. And so him and his team published an article about improved survival and morbidity after the setup of networks. And as you can imagine, there's no one thing that led to the improvement. It wasn't because air ambulances were set up. It's not because there were faster A&Es, and not because of surgical issues. It was just a whole system-wide improvement that led to better patient outcomes. And in terms of like specific positive impacts, so pre-2010 and pre-trauma networks, as I said, morbidity, mortality weren't great. If I were to give you an example of open fractures, okay, so that's a fairly straightforward thing. We've all seen them all the time, and it's a fairly common injury. And so prior to 2010, and I was working as an orthopedic registrar at that time, patients would typically go to their local hospital with an open fracture, whichever hospital was near the accident. They would then get completely treated there, start to finish. And if they needed any plastic surgery for a large wound that wasn't closable, etc., they would get all the orthopedic surgery done, then get transferred to a plastic surgery center, and then have the plastic surgery done separately. With the development of trauma networks, what that did was you ended up having orthopedic surgeons and plastic surgeons co-located within the same building. So patients would typically now have all of their interventions done by orthopedic surgeons and plastic surgeons together. So the outcomes of these patients, if you look at deep infection, for instance, is significantly improved. So the international outcomes for deep infection for after open fractures, depending on what paper you read, is up to 30%. Okay. In the UK nationwide, it's less than 10%. And then in some centers who are having a really efficient system, et cetera, you can get results of 2 to 4%. So there's a paradigm shift in open fracture care just through setup of networks. And how those management pathways were guided was through national guidelines from the British Orthopaedic Association and from NICE as well, so the National Institute of Clinical Excellence and Health. And so all of that within the framework of a network led to better outcomes for such patients. And then, that's obviously evolved now with pre-hospital care teams, ambulance crews, etc., trying to go for those marginal gains of giving patients antibiotics at the scene, tranexamic acid at the scene, trying to get those patients bypassed into the trauma center.
It's really interesting to say that, actually, because there is micro analogs across the system. You speak of, and quite rightly so, like the adage of having co-located services as specialisms, so you can catch the infection and catch the, treat the patient definitively for different pathologies across their care pathway. The same happened within urgent care, really, the co-location of GP surgeries within A&E, so that, and again, it's different but similar. It's knowing that actually co-location actually saves time, saves energy, and saves patient time fundamentally. So there's lots of these little gains that have kind of been cleaved from that. Can we pivot slightly, Ash, and look at some of the contemporary challenges that the major trauma networks have faced? And I wonder if you could just speak to some that you have maybe bumped up against yourself or that have become apparent in the last few years.
So there are a number of issues, I guess. And sorry, if I just may finish on the open fracture, just in terms of that now, because of the significant improvements, you'll find a lot of the stuff that's happening in the UK is now being looked upon by other countries outside of the UK, so Europe, Australasia, and North America, looking to us for advice in terms of how to improve their networks to get these things. So it's just, from being a country where we were looking to others, it's now rolled back to others looking at us for certain things. So it's, that's great. But all of these positives do come with challenges. I mean, everyone knows about the significant infrastructure issues with the NHS, and that probably is the biggest thing because it has a huge knock-on onto how major trauma care is managed, and it affects all the services within any hospital, be that a trauma unit or a major trauma center. So, for instance, the very limited patient flow, typically either due to lack of social care support in the community, and various issues like that, make it very difficult now to have patients, unless they're kind of clinically very unwell. It makes it very difficult to move patients from a trauma unit to a major trauma center very quickly to have a care done in a appropriate time manner. So there's a lot of delays in transfer, except obviously for the unwell patients. So, I mean, they just get transferred because they go from an A&E to an A&E, that's fine. But once someone's admitted to hospital and waiting for a bed to be freed up into a major trauma center is a significant delaying issue. That's a single issue in my region. It is in other regions as well. Interestingly, some networks have better social care in the community. And so you find other networks don't have it as much of an issue. There's a lot of argument or discussion in kind of surgical worlds about de-skilling, and I guess it's an issue in the emergency department world as well, because clearly you get these complex cases that end up going to one particular A&E and one particular hospital preferentially. So what happens with those surgical teams and emergency medicine teams in the other hospital? They don't tend to see them. In all honesty, yes, there invariably is a bit of de-skilling, okay? But what we try and do is encourage surgeons within our regions to stay in touch with the trauma center, try and do lots of educational events so they can stay up to date with what happens. And actually, a lot of our national orthopedic meeting, for example, has tons of sessions about trauma care so that everyone around the country is is able to attend these sessions, stay up to date with evolving technologies and surgical treatments for major trauma patients, and just keep abreast of what's going on. Interestingly, when COVID happened, we couldn't do transfers that easily, as you can imagine, because of the infection issues, and so we ended up requiring the support of our trauma units to do more surgical interventions than they would otherwise have done. But they stood up to the challenges and actually performed really well and helped us manage all of the patients at a time when we couldn't do rapid transfers.
So, Ash, looking at something you just mentioned there, which is really interesting, is around resource allocation and also exposure, allocation of exposure, because, like you said, what's happening with when and the major trauma tree, certainly for paramedic colleagues or pre-hospital colleagues, is being triggered. These patients are passing or bypassing the usual A&Es and going to the major trauma centers. You've spoken to, like you said, the compensation there for training that some of the trauma units, so they're not the major trauma units, the trauma units don't get to see, so that they get the training, they get hopefully the exposure that way. Could I get you to speak to some of the other resource allocation issues that are being corrected, such as just trained personnel in the right places, spreading the experience across the network so that actually there is a meld of, because one thing we certainly can't mitigate is people that walk through the door with major trauma center into a trauma unit with a
Yeah,
knife in
yeah,
their chest or just
yeah,
been
yeah,
run
yeah,
over outside the door. And
yeah.
how across these networks is the experience and indeed training sort of being spread?
So if I just focus predominantly on the doctor speaking with, because obviously I have more kind of sight of that. So a lot of registrars who are training or in training consultants who are, will at the end of whatever 5 to 7 years become consultants. A lot of them now in their training program, there is a stint where they have to work at a major trauma center and there's an opportunity to work there. So they get a lot of major trauma experience over a period of a year where it's rapidly taught to them. And for instance, where I work now, we've just had our new influx of registrars. Pretty much, I think about 80% of them have not worked at a trauma center before. So this is a great opportunity for them. And already, a couple of them have been in theaters and their eyes are like lit up because they're seeing cases they would have never seen before. And so, as I say to all of them, there's trauma and then there's trauma. And so at a trauma center, you'll see a huge level up of potentially from the orthopedic perspective of what one would consider trauma. So, a simple ankle fracture doesn't really register to us in our spectrum of injuries that we tend to see, whereas a very comminuted multifragmentary pelvic fracture is kind of something we see quite often. So we want to make sure all the doctors in training see that from a surgical perspective. There's a lot of opportunity to also understand and see how the other specialties within a trauma center work. So you can spend some time and learn how the neurosurgeons work, how the general surgeons work, learn how anesthetics and ICU work and how that's different. And that's something that's there for kind of all the surgeons and doctors of different specialties. So emergency medicine doctors will have the same experience. Anesthetists, intensive care doctors will all have that experience of being able to work. I think in terms of nursing, I wouldn't want to say too much because I'm not hugely aware, but what tends to happen is most trauma centers run courses for all clinicians and allied health professionals to support them in their kind of education. So we run courses where ED staff, theatre staff from other hospitals will come, and then we'll discuss cases. And for example, for the ED staff, run through trauma scenarios such as stabbing to the chest, someone struck by a motorbike, all that kind of stuff, and how you would manage them if they're brought into your emergency medicine department, and how you may have to, because sometimes there isn't time to transfer them out, may have to do some life-saving interventions. So it's all about making sure that everyone's equipped to do it, because yes, you're quite right. There will be quite a few cases that will come through your door where you need to do interventions, because if you transfer them, they haven't got the time to get to the major trauma center in order to have those life-saving interventions. So you've got to do it first.
Ash, could I talk to you about communication really, and two levels of communication? So it is kind of a split question really. One would be more lower level communication that you see and interact with within major trauma networks, maybe around M&M meetings. So debriefing cases across the network, and indeed with other networks, and whether that sort of shared learning occurs. And the second half of the question would be, have you got set um, patterns of communication, or indeed protocols for communication when a major trauma, sorry, a major incident occurs, so that actually there is coordination amongst the network in a major incident, and that you can start to understand the flow of patient transfer.
So, as you know, King's is in London. So, unfortunately, we have some experience of managing major incidents, and clearly our colleagues in Manchester, etc., also have the same thing. So, I think over these, having these experiences over recent years as well as historically, there have been improvements in communications, because I'm sure you know that a lot of the inquiries into any major incidents, the first thing that everyone says communication, and no matter how much we try and improve it, I suspect it'll be the first thing in every subsequent inquiry from now on in. And it's just a case of trying to make it as optimal as one can. So there are set pathways about how pre-hospital care services would liaise with the region, or with the nearest major trauma center, how they would then organize different patient groups to go to this trauma center. Maybe some would go to another trauma center, maybe some would go to the local trauma unit, and it's to make sure that you use the full spectrum of hospitals and services available to you. But that would pretty much happen at a very strategic level, so kind of a gold silver kind of level. And then us worker bees like you and me, Owen, would be very much in the bronze level of doing stuff for patients. There's that. So that's in a kind of major incident level, and that's pretty much on everyone's radar. I think a lot of the regions have a similar setup. There's a lot of collegiate working. So, for instance, within the last year in the east of England, there was a big major incident exercise with, fire, police, all the ambulance services, and then all relevant pre-hospital care teams as well. And part of that would then be a kind of a tabletop exercise into the hospital to see how that would function. And then within that, within the hospital, the major trauma governance teams would keep an eye on that to make sure there's appropriate plans set in place. And this is where action cards come into play. I think it's probably very much more difficult to have a full exercise in a hospital, because it would mean actively stopping a lot of things, and there's quite a significant number of logistical issues in doing that, because there's always things to be getting on with from a clinical perspective, and I think it'd be very difficult for a hospital-wide training exercise to happen like that. So I think the best way that it does happen is the pre-hospital exercises liaise with the emergency department, and then the emergency department on a separate day, separate event, will have plans in place to liaise with other departments. In terms of day-to-day, there is regular communication. So if I just talk within my region, which is not hugely dissimilar from quite a few other regions, you could imagine that there's a lot of patients going into trauma units, into major trauma centers. So people that come in directly to major trauma centers will just sort out. There are some patients that will go to a trauma unit. If that patient needed to go to the trauma unit but was clinically compromised, what typically happens is they just get routed straight back into an ambulance with or without any interventions, depending on what's required. So if there's an urgent airway intervention, that'll happen. An urgent blood transfusion, that'll happen. And they may then go back into the ambulance without a clinician, and then come to the major trauma center. Ideally, that does tend to happen with a little phone call where the emergency medicine doctor in the trauma unit calls the major trauma A&E doctor at King's, for example, just to give a little perspective of what's coming their way. It's not necessarily to seek permission, it's just out of courtesy, so they know what's coming, so they can be prepared, and so they can do a trauma call, etc. It's definitely not seeking permission. So that's on a major trauma perspective. There are also complex isolated cases where it would, for example, someone with a stable pelvic fracture, for example, may just go to the trauma unit because they're stable clinically, hemodynamically stable. The pre-hospital team, when I say pre-hospital team, I just mean the spectrum of everyone, may not realize it's pelvic injury, which is fine, or there's no immediate need based on their major trauma triage tool they're using for them to go to major trauma straight away. And that's fine. They get admitted by the orthopedic team at the trauma unit, and they will then call us for advice. So we use, for example, where we work, we have an online referral system. So it just goes all in the system with all the various details. All the imaging, CTs, X-rays are all image linked across to us. So we can see everything. They can also on this system send across photos, etc. So it's actually makes it fairly easy to kind of then provide them with timely advice or accept the patient for transfer, and then we'll bring them over as soon as feasible. And that happens across a number of different specialties, neurosurgery as well, and then in medicine across the renal physicians as well, and liver, for example, gastrointestinal. So a number of different specialties are using similar referral pathways. And so that's how kind of that happens in a day-to-day team. And then you mentioned debriefs and M&Ms. So there, yeah. So all trauma centers and all hospitals generally have regular M&Ms, M&M meetings, mortality, morbidity. That'll happen at a major trauma level for all the code reds, for example, that come into our hospital, all the complex trauma cases. And in fact, there's either one this Thursday or the following Thursday. So that'll get discussed. And again, any feedback that needs to go back to the trauma unit will go back. And then there's also a regional wide meeting as well, where where needs be, cases can be discussed. Most trauma units also have a governance lead whose job is to kind of ensure that these governance activities and meetings happen regularly, but also to feed back and action any learning points, whether that's for the major trauma center, for the network as a whole, or for the trauma unit.
So I was just looking at, and you kind of answered it in that last question slightly around technological advancement, around sharing of images and maybe this plenary, this MDT, multidisciplinary team approach, which is fantastic, really. One of I guess my angle for this question might be more around research actually in garnering data, because I think maybe one of the adages of having a major trauma network is that you can start to really cleave data because there is ubiquitous information sharing, this information sharing across the network, and there's also hopefully a semblance of patient follow-up and patient follow-up data. Could you speak to your experience, or indeed what you know of just how much that helps foster the ecosystem of good data collection for research, and how much easier it makes hopefully good research from air ambulances as well, because air ambulances have got research fellows attached to them, and does it foster better or indeed more robust research and data collection?
In terms of data, I think, yeah, the technology's there. I think it's largely dependent on whether the system's there in any respective hospital. The issue has always been that there's, as you say, a multitude of data, whether people actively gather it and then whether people actually look at it. The National Institute of Health Research, one of its big things that it's looking at is trauma care and research into trauma care. So King's actually is a big center for recruitment of patients into national level trials, especially orthopedic trauma trials. And so these are usually sponsored by a big center such as Oxford or York, or sometimes Nottingham, etc. And so a recent example would be the ORIF trial, which is an orthopedic trial looking at rib fracture fixation in patients with significant rib fractures. And so a lot of major trauma centers actually were recruited, not all, but a lot of them were recruited into that large study. And we're all trying to, on an individual basis, recruit patients for that study. And so what will then happen is part of that, a lot of departments will have a little research team within them. So in orthopedics, where I work at King's, we have a recruitment team led by one of my colleagues, Inez. And then the big orthopedic rib fracture trial was run out of Nottingham by another colleague, Ben. And so with that kind of centralization of the trial itself, all of us hospitals that were part of it would have to follow up the patients, collect the data, at 6 months, 1 year, etc., and then give the data back to the central hospital that was running the study. Sometimes they would contact the patients directly. So a lot of the systems are in place to run big trials like that. The other aspect of collecting data is just for kind of general mortality, morbidity, just to monitor performance. And clearly that was something TARN used to do. So that's a trauma audit and research network, which is run out of the University of Salford. At the moment, that is shut because the plan is to set up a new system, but it's been shut for a little while. So there's a little hiatus at the moment. But what used to happen was, as a hospital, you would need to collect data about major trauma patients. When they came in, you'd have to collect physiology parameters. You'd have to find out their time to CT. Were they reviewed by a consultant within 30 minutes, etc., or on arrival? And all of these were associated with kind of KPIs that TARN used to then determine how well a hospital was performing as a major trauma center. And then based on that, you would then, as a hospital, kind of get reviewed by TARN to say, actually, you could improve this. This is actually, or this bit that you're doing is really good, this not so good, etc. And so at the moment, that system is not quite fully set up again because they're just sorting out the next iteration of TARN. But to be honest, which I'm not entirely sure how it's going to run, but that's kind of setting up in the background. Instead, what's happening is kind of most trauma networks do their own review of the trauma units and the trauma center. So for instance, at King's, we are part of two networks, the London Trauma Network, and then this kind of the CellCam network, which is Southeast London, Kent, and Medway region. Okay. And so the network itself will assess our performance as a trauma center and kind of look at, how well we're admitting patients, how well we're performing, are there any issues that we could improve upon, etc. And the same system. So we had one recent review a year ago by the Southeast London Network, etc. And then in the last few months had another review by the London Trauma Network. And so lessons from that is something that we have to then, put into place moving forward. There's an NHS England wide review called GIRFT. So that's getting it right first time, which is run by Professor Tim Briggs. He's an orthopod, but he's looking at multiple different specialties. Major trauma is one of them. And so then they go around the different networks and centers, trauma centers, to look at how well people are performing. Is there anything, again, they could improve upon and to put into place? So that's how the governance side and the data side from that perspective is run. When TARN was around, because it collected a lot of data, there was actually a lot of opportunity to look at outcomes and publish. And so a lot of teams actually looked at performance of how open fractures were managed, how pelvic injuries were managed, was everything done in a very quick manner. So that was really, progressing well. It was a little disparate between different hospitals. Some trauma centers had a lot of administrators who were able to collect the data really quickly and very accurately. Other trauma centers only had one or two people doing it. So it was very difficult for the data collection to be up to date in those instances. So there's some variability, but you're right. Overall, data was being collected, was being used to assess performance, so for clinical governance, and then also being used for research trials for novel information.
Ash, could I get you to, you've already spoken to outcome and the improvements in mortality and morbidity from the networks. Could I get you to speak to just the long-term recovery for trauma patients? Because I think mortality is one thing, but quality of life is something entirely different. And returning to, I guess, a CPC or cerebral performance category of 4 to 5, which is, normal tax-paying status, but just fundamentally enjoying life again and getting back to the normal sort of pleasures of life. Could I get you to speak to how major trauma networks have added and indeed benefited long-term recovery?
So I think there's a big breath in before I answer that. So within the UK, I think that's actually one of the biggest things that we're not doing that well as an overall system. I don't think necessarily it's the fault of the network or the fault of this trauma center or anyone's fault per se. The rehab side is a real limiting factor. There is, again, regional variation, with some regions having better access to kind of cottage hospital type facilities or rehab facilities. But to be honest, they're very, very few and far between. So where in the region I work in, there's a couple of rehab centers for amputees. And there's a few rehab centers for head injuries. There's very few for spinal cord injuries, and what they are is about three in the south, central south and southeast of England. And somehow everyone's got to get to those centers, and there's a big waiting list for them. And there's some private rehab facilities, but I think NHS style paid for tax funded facilities are really limited. And if you speak to a lot of the central clinicians at a high strategic level within NHS England, they will say that if they had the opportunity, the next fix they would try and do for major trauma is not necessarily about improving things in the hospital, but is to sort out rehab. And I think we could definitely improve that. I mean, you obviously know about head injury and how debilitating even a mild to moderate head injury could be. If I were to tell you that there's been a lot of studies in open fractures, so open fractures where they've looked at overall disability rating index, so kind of general how people are. Open fracture patients suffer as bad, if not worse, than stroke patients. So there's a lot of morbidity with kind of even relatively simple major trauma cases with just an isolated open fracture. And there's a big problem of getting patients back to work, paying taxes, and as you say, just enjoying life with their families. And there's a disproportionate number of very, very young people involved in this, as well as the kind of older silver trauma type patients.
Ash, good. As we start to come into land on the conversation, a couple more questions really. One would be if you could just maybe illustrate for listeners and indeed viewers, just maybe a case study, a generic case study, just to illustrate how powerful the change into becoming a major trauma network healthcare system has become, coming maybe through even indeed with the pelvic or indeed multi-system trauma into one of these networks, into a major trauma center from a pre-hospital care service like Essex and Heart Ambulance. Could you just sort of illustrate how powerful that change has become from a case study, just to really cleave the 1% and improve outcome?
Okay. So there's one case, there's a couple of cases I'll never really forget, right? There's actually quite a lot I'll never really forget for various reasons. So if I remember when I was working in Essex, in a normal trauma unit hospital, district general hospital, very good district general hospital, I was doing emergency medicine block at a time. I was working as a senior house officer, so just the level below a registrar. And we had a young adult, I think it was 18, 19, who was cleaning his Airbnb gun. And as with anyone, you should never look down the barrel of a gun. He did, and he accidentally fired. And so he got brought in by a ambulance crew to us, which is quite right. Okay. So he got brought in by us, and he basically was like talking away, but clearly had a dressing on his eye. And so I remember kind of, taking the dressing back, and obviously it's just a lot of damage there, but you couldn't see anything in terms of the projectile, right? But he had contralateral complete weakness, not really able to move anything, and absent cessation. So my concern was clearly this projectile has, and I know nothing about, like, I know now, but back then I knew nothing about kind of Airbnb. I couldn't really tell the difference between that and an actual gun, but that had clearly gone through his eye and was sitting somewhere in his brain. That's the only way to could explain any of his, signs on the other side of his body. And I remember it was a complete struggle. I remember kind of, so we got assessed the patient, we did a trauma call, so we got loads of people to come, and he was there kind of talking and stuff, and so there wasn't really a huge amount to add. We needed to find out where this projectile was. I remember speaking to the radiology team that day and saying, we really need to do a CT scan, right? So Owen, for you and me, this is clearly barn door, right? That's what needs to happen next. But they would not let this CT happen unless I got a skull X-ray. And I'm like, I just couldn't believe that I had to walk this step of a skull X-ray for no particular reason. So we got it, yes, on the skull X-ray, it's inside what would be in the brain, right? And so then the doctor in the radiology was like, so what do you want a CT for? And I want to see where it is in the brain. It's quite a big space. And they're like, well, it's in the brain. Does it matter? And I was like, well, I don't know, but the neurosurgeon's going to ask, right? And then it was a struggle. Eventually we got the CT scan, but honestly, it was like, it was like, it was that radiologist's personal machine that I had to apparently ask a favor for. It's just quite frustrating. And we got the CT in the end. And then it took hours to even find a neurosurgery department that would accept the patient. And where we were, there are 3 that are nearby. And in the end, reassuringly, the Royal London, as it always does, just says yes. And so we got the patient transferred out. And clearly, and sadly, the patient did pass away, as one would expect, with this kind of injury. But it was just at the end of it, I was just so surprised that it was such a painful experience to just even basically investigate, let alone treat a patient like this. And I thought, well, and so I was at that time already like really wanted to pursue a career in trauma, but I was thinking at that time, God, it better get better than this because I can't be dealing with this. Okay, so then this was probably 2008. No, actually, correction, 2005. So then roll 2010, trauma networks had basically opened up in London. And I remember driving into work and I just got placed at King's as a year 2 orthopedic registrar. So King's had literally the day before opened as a network. I remember driving into King's, driving down like East Dulwich Road, heading into King's. In the morning is like 7 o'clock. And then there was the news bulletin as it usually comes up. So the news bulletin had said that, forgive me, 8 o'clock. So the news bulletin had said, this road is closed, that road is closed. And then I was thinking, oh, thank goodness, I've just driven past there because I'm on my way to work and those roads that were closed were behind me. And then it said, elderly lady hit by a car. That's why there's an accident. And so, that's why the road's closed. And I was thinking, oh, okay, so chances I should probably come to King's because we're now a trauma network. It should come to us. So then I got there, and that day was my operating day for trauma theatres. So there was this late 70-year-old lady with like a C2 fracture, a thoracic spine, lumbar spine fracture. Forgive me. I'll just put that phone down. So there was a C2 fracture, then a thoracic and lumbar spine fractured. She suffered a pelvic fracture as well, a femoral fracture, and then some kind of lacerations here and there. And I think there was a liver injury as well. And then she went through the system, went through A&E, had her CT straight away, seen by a consultant, resuscitated appropriately, brought in by the normal ambulance crew, not a HEMS mission at this time, brought in by the normal ambulance crew, and then did that. She got to theatre. So spine teams didn't need to fix any of her spinal injuries per se, but gave some precautions. We then went about fixing her orthopedic injuries that day. She went to ICU, and then within 3 or 4 days, she was on the ward. So she had a brace for a thoracic lumbar spine brace, and then for the neck, they treated her with a collar. And I think that later on, about a week or 2 later, the spinal surgeon then went in and then fixed her spine because they were concerned that actually if they left it to heal on its own, it may not unite, and so they just wanted to address that issue now. So they did all that, and then she kind of walked, I say walked, but really hobbled. But she hobbled out of hospital about 2 weeks later. And I was astonished because I was like, I would have bet significant money that the outcome would have been very much poorer prior to trauma networks because, I couldn't see how she could have done really well were it not for the trauma network. And that kind of case I'll never forget. That's the one that always sticks in my mind when someone asks me, can you think about a case? And I'll say, yeah, that was the second day of a trauma network showing profound improvement in someone who, if they'd gone to the local hospital that didn't have neurosurgeons, didn't have kind of orthopedic trauma interested surgeons, would not have done at all as well. And I think that the key thing about trauma centers is when trauma centers were established, networks are established, there was no money to give. They just kind of happened. And in London, they happened on the back of kind of PCI and heart attack centers. That's how they, and so, it was kind of sneak through and made it happen. And all it was just about co-locating interested people and a little bit of equipment. That's literally all it was. And then with that, you just set up pathways to make sure people move smoothly down the line within a hospital, within the trauma center. And then also people moved from trauma units to trauma center in a smooth fashion. And I think that's, for me, those 2 cases are just paradigm differences of outcomes. And I don't think that young patient I gave you at the start, I don't think his outcome would have been that different, to be honest, even if he got to a trauma center. But just the pain of trying to get an investigation was like, oh, excruciating. And it's a world away. And so when I speak to like registrars coming through now, I remember a time when you couldn't get a CT scan for money or anything. Whereas now they're just done almost as commonly as putting a line in.
Yeah, it's profound actually, Ash. And as you said, it's and not knowing the history. Doesn't belie or doesn't infer how much we've evolved as a system, really, and
Mm.
how efficient it is now compared to how it was. And those two are powerful examples, actually, really powerful examples. Ash, just as we come into land on the conversation, just one really final question would be just any take-home messages. Quite rightly, as you say, there is other countries looking at the UK right now and how we operate major trauma networks within the wider health ecosystem. Could I get you to speak to just some take-home messages around what you've learned since working as indeed the trauma lead at a major trauma center such as King's, and indeed, if anyone was to want to institute a network within their system, just a few salient take-home messages that you could give.
So at a trauma center where I work, I'm in a privileged position of being at a place where everyone within their different specialties is very interested in trauma. Okay. When I say everyone, it may just be a few people, but there are, a lot of people are interested. So it's very easy to kind of discuss with different people about how we can change pathways, implement change if we need to. It's not the hardest thing in the world. And so, for instance, I get a lot of new doctors coming through and also asking, so we could do this better about communicating with our hospitals. We could do a referral system that was better. For instance, when I started at King's, a lot of these referrals from other hospitals were just phone calls. And so off the back of that, actually, one of my F1s, so, a doctor who had just come out of medical school, she did really well. And she actually thought, well, we got to do it better than this. And it's because, for them, they were, a generation that's only known social media and computers. And so she set up a website, and so everyone was doing web referrals. And then we ended up buying a contract with a company that had a much more kind of fluid system that was just much more mature. But so there was things like that, and and in the position I was in then, I was just able to implement that like within a day. There was no issue. I just said, yeah, write the website thing, and then as soon as you've done it, I will send an email to every single orthopedic surgeon within our trauma network to say, if you have any more referrals from this date onwards at this time, you now need to do this, this, and this. So go to the website, follow the instructions, refer the patient, and then I will screen all the referrals. And so myself and two other colleagues ended up screening every single referral for about a year and a half ourselves. Now we share it with a much bigger group, which is fine. And so it was easy to implement change. If you wanted to implement change in a region that had no trauma network, I think the key is to find allies within your other hospitals. Yeah. So in your trauma units, if you want to be the trauma center, you need to find allies in different departments. You need to decide if you could even be a trauma center, because there are certain specialties you need, right? You need neurosurgeons because there's little point being a trauma center without people to manage head injuries. You need some form of general surgeons that are interested in managing traumatic injuries, not just in general surgery of like abdominal problems and appendicitis and stuff, but people are interested in managing stab injuries to the liver, blunt injuries to the spleen, etc. You need to find interested people in radiology who are interventional radiologists who can manage bleeding with embolization, etc. You need to find that spectrum. If you've got all that, you can definitely support an argument that you need to be the trauma center. But the key thing is then to find allies in all your surrounding hospitals and then see if there's an argument to have a network where you can work together so that patients get sent to the correct place. I mean, that's at a local level, but clearly to establish a formal network, you really need to kind of get the higher echelons of management involved, so that's the executive management trees in the different hospitals. And then effectively you would need to approach them with a plan where for your trauma center, it's a good thing to be the trauma center. Yeah. So, it's a good, it's popular to do that. It's well regarded, you're respected, you could do that. Maybe there's some remuneration in that. And then for the trauma unit, the benefit would be from an executive point of view, you're offloading them a ton of cases that they don't need to do. And especially if they are a busy elective center, for example, for planned surgery, then it's good that they are able to do that without the stress of managing emergency cases that come in and wreak havoc within the system.
No, Ash, that's fantastic. And some really good points there, some top of mind points. But also, what I really like about that is, like you said, the collaboration and the wider collaboration that can also, and to your earlier point around the website, it's there can be some really simple workarounds that actually start to foster that collaboration and share caseloads and share perspectives. So that's absolutely fantastic. We will put in the show notes some links to the review on the major trauma networks, the latest and certainly the latest one as well, just to illustrate the evolution of major trauma networks. But listen, just want to thank you, Ash, for your time and perspective. It's fantastic just to get your insights, but also just to get your unique perspective from a well-functioning trauma network in London, and just how that's evolved over time. So thank you.
No, my pleasure. Thanks again for the invite, Owen.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.